very much, co-chair ladies. Now, there's a reason why they call it special applications. That's because it is not commonly done. So these are tests that you would do under specific people. You can also consider microemboli monitoring. I'm also going to talk about cerebrovascular reactivity and sonothrombolysis, which is TCD monitoring when you are giving IV thrombolysis. So first, the clinical patient. 32-year-old lady with no significant past medical history, an uncomplicated obstetric history, no cardiovascular risk factor, not a drug user, and no family history for stroke, heart attack, or any form of venous thrombosis. She had been sick prior to coming into the hospital, sore throat, running nose, coughing, taking medication. She came back to work and she was still coughing intermittently while she was at work. Then she developed sudden onset of left face, upper limb, and lower limb numbness. The numbness persisted, but it fluctuated. And she was an intelligent lady. She thought something was wrong, so she came to the hospital. And neurological examination was consistent with a mild left hemisensory loss involving the face, trunk, and limbs. The initial investigations, blood tests were all normal. We did a cardiovascular risk factor. We looked for autoimmune disease. We checked HIV, VDRL, they were negative. ECG was sinus. There was no history of palpitation. We still went on to do a 24-hour Holter, which was sinus. MRI did not show an acute stroke. But because she had symptoms for an acute stroke, we labeled her a DWI negative stroke. More importantly, her vascular imaging was normal. Intracranial circle of Willis was normal. There was no stenosis. Extracranial carotid arteries were very clean. So we checked her risk of paradoxical embolization score. If you look at her score, she scored 8. Now, a rope score of 8 means that the possibility of PFO causing her stroke was as high as 84%. With this in mind, we went on to do a test for paradoxical emboli. So this is the TCD. We did it first baseline. She was lying down. We did nothing but inject agitated saline. We found 1 microemboli. So we repeated it at rest again, and we found another microemboli in another vessel. Then we did agitated saline with Valsalva effort. We checked that Valsalva effort. So with a moderate effort, fair to good effort, there were more microemboli. And this time we told her, really give us a good effort. Push down, push hard, like you're very constipated, and push. She did it, and there was a shower of microemboli. So she had a positive test. Right to left shunting was demonstrated with 1 microembolus detected at rest, and with very good effort Valsalva maneuver, there were showers of microemboli. With this information, we call our cardiologist. There is paradoxical emboli around. Most common cause, still cardiac. However, our cardiologists are very cautious people. They know that PFO is common, and they didn't want to be surprised by an incidental abnormality in the echo. So they said, do a normal transthoracic echo. We don't want to find intracardiac clots or rheumatic valvular disease. We don't want to be surprised. So a normal transthoracic echo was done without agitated saline and was normal. So the cardiologist spoke with the patient. You probably do have a PFO. If you're agreeable, we'll do a transesophageal echo. And if we do find it, we can offer closure. So the patient said, yes, let's go ahead with it. So TE was done with sedation. And at baseline, the cardiologist already saw some bubbles shunting, but they didn't write the number of bubbles they saw. And with a good Valsalva maneuver, like the paradoxical test that we did, they found a large shunt. The PFO was closed the same day uneventfully. So what are the criteria you need before you do a microemboli detection? At the very least, like you heard all my previous speakers say before, you need good temporal windows. If you don't have temporal windows, it will be very difficult. Fortunately, most times when we're looking for paradoxical emboli, these patients are usually young strokes, so the windows are not an issue. And of course, you need to have a comfortable head frames that can hold the probes. Otherwise, you'll have to hold and be very steady. And believe me, it's very difficult to be steady when you're breathing and doing Valsalva maneuver. You want a head frame. Of choice, you always monitor both middle cerebral arteries because these are the two largest intracranial arteries in the brain. If the windows is not good, you will always try to insonate middle cerebral artery and contralateral PCA or anterior cerebral artery. The first choice is always bilateral MCA. So coming back to microembolus, as you know, blood is full of cellular components, and these cells, the red blood cells and white blood cells, because they are in blood, they reflect ultrasound beams back. And with this, we're able to get a Doppler flow of blood flow because of blood cells flowing in the blood and reflecting back ultrasound waves. If there is a microembolus in the blood, and that microembolus is a strong reflector of ultrasound, guess what? It'll reflect a stronger signal, a louder signal than the red blood cells and white blood cells around, and it manifests as a transient high intensity signal. Why is it transient? Because when we do TCD, we listen to one spot in the vessel, and the microemboli passes through it very fast. So it's always very short. And it has to be loud enough for us to hear. In other words, a microembolus that's very soft, you may not pick it up. In the blood, there are many sources of microemboli. It could be fragments of ruptured plaque. It could be a clot from atrial fibrillation, or it could be fat emboli from a fractured femur. Alternatively, you could have gaseous emboli, such as when you have mechanical valves, because mechanical valves create a lot of turbulence and there are a lot of gas emboli. Or you can introduce it with a syringe with agitated saline. Not every high-intensity signal that you see is a microemboli. To be defined as a microemboli, you should fulfill these 4 criteria. It should be transient. I told you why. It is recommended that the amplitude should be more than 3 decibel higher than the background noise. Now, if you lower the amplitude, your sensitivity will increase, but your specificity for microemboli decreases. So it's better to have it slightly higher. It must always be unidirectional because the microemboli is flowing with the blood, so it has to be one direction. It can't go backwards. And microemboli always has a characteristic sound. Chup, mo, snap. There will always be a noise. I'm not very good. Artifacts, on the other hand, are usually low pitch, like this, and bidirectional. And it's because someone's moving or talking. Another thing is speckle. A speckle is something that you think is slightly bright in the Doppler spectrum, but this is just random variation. We don't know what it is, and that's why we have a criteria for microemboli. More than 3 decibel comes with a noise. What are the technical considerations when you're about to do microemboli detection? First, gain. You must put your setting to the lowest gain. So instead of having a Doppler that's very bright, you put it very low so that the whole Doppler of blood flow is a light blue color. That way, if you have a microembolus that's loud, you can see it loud, clearer against the background. 2, like I said, detection threshold is recommended 3 decibel and above. 3, the dynamic range. That is the minimum to the highest frequency you can hear. Now, if your microemboli is a very good reflector, it can give a huge noise, then your dynamic range is exceeded. Like in this picture, what has happened, this is a gas microemboli, and it's given a very loud reflection. It has exceeded the dynamic range of the TCD, so an artifact has occurred. It seems to be bidirectional, up and down, but this is an artifact because of the very, very high signal from a gas emboli. And fourthly, the recording time. If you're doing microemboli recording, the longer you record, the higher your chance of catching a microemboli, because microemboli do not appear when you wish it. They appear whenever they want to. Now, this is an example of a microemboli and TCD. So you should be able to tell me what is artifact and what is microemboli. Is that microemboli? Is that microemboli? Is that microemboli? That's microemboli. Did you hear the difference? So in the first part, it was a continuous noise without the chirp, 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 chirp. And the whole thing was red. That was the patient clenching his teeth very hard because he was doing a strong valsalva until his muscles clenched. Then, because it was positive, you heard all the plup, plup, plup together with the speed. So this patient had both microemboli and artifacts. How do you do a test for microemboli? Preferably, you always insert an 18 gauge, the green needle, in your right arm. Why? Because it's the shortest distance to travel back to your right heart. Bear in mind, you're injecting agitated saline. So the shorter the distance, the more the bubbles survive. So try not to do it on the left arm. By the time you go back to the left heart, to the right heart, you have fewer bubbles left. Then you try to monitor both MCAs. We use a 3-way stopcock, and then we will agitate saline, 9 ml saline, 1 ml air, and we agitate this way until it's quite creamy, and then we inject it at rest. And repeat the same technique, but with valsalva. When we perform valsalva, we inject, then we ask the patient to do a very strong valsalva for about 5 seconds, and then release, and we monitor for 60 seconds. If the patient has done a very good valsalva, your TCD will actually show a reduce in velocities. That is a good valsalva. There are 2 ways you can grade microemboli detected. We use the international consensus because we use the blind TCD. With the blind TCD, there's only one gate open, and any one time, microemboli is only measured through that one gate. So the international consensus would be negative, 1 to 10, more than 10, or a curtain. Very simple, because like you saw in the example I gave you, it's impossible to count the microemboli when there are a lot. The Spencer scale, on the other hand, counts more emboli, and that's because the Spencer scale uses a different technique. So this is an international consensus, and on the Spencer scale, they use the power motion mode Doppler, and the power motion mode Doppler has many gates. So from the ACA to MCA, there are like 10 or 11 gates, and so they can track the microemboli moving from proximal MCA to the distal MCA. So you can see literally track every microemboli moving from proximal to distal MCA. And that's why they can count the microemboli more detailed. So this is an example. A power motion mode Doppler would measure this whole depth, have many gates, and they show it up as color bands. Red for MCA, blue for A1 away, and then red for A2, and they can track a microemboli crossing across. Our lab does not use the power motion mode Doppler, so I won't talk much about it for the rest of my talk. Now, if your TCD is positive for a paradoxical emboli, the most common cause is usually a patent foramen ovale, rarely atrial or ventricular septal defect, because at birth, these defects usually cause murmurs. If your cardiac screen is negative, it might be due to a pulmonary arteriovenous fistula. So if your cardiac investigation is negative, you should do a CTA to make sure it's not a pulmonary shunt. The gold standard to confirm is always a transesophageal echocardiogram with and without Valsalva maneuver as well, because the Valsalva maneuver must be done to increase the pressure in the right heart. So if you have a shunt that opens intermittently, when the right heart pressure increases, like when you're coughing or trying to pass motion, it will push the bubbles across. So it must always be done with Valsalva. Excuse me. Transthoracic echocardiogram can be done, but it is not as good a screening test as transthoracic echocardiogram. Firstly, the patient lies on the side, and the echocardiologist has to hold the probe quite steadily while they do the procedure. And secondly, just as TCD has limitation like poor temporal window, if your patient is very big, the echo can be less clear because you've got a thick chest person. And in echo, you're actually looking for bright little spots inside the left atrium that tells you that is bubbles inside the heart. You cannot hear the sound like in TCD because the heart is beating at the same time and the heart is very loud, pum, pum, pum. So you will not hear any sound, you just look for bright spots. So TCD is easier to identify. So this is an example of an echo, and you see little dots filling up here, and then it goes across to the ventricle. So it's gone to the left atrium and going to the ventricle. And you hear the cardiologist talking in the background because they don't bother to hear. You can see, but you can't hear it. It's just that the heart is beating too loudly. So the cardiologist would just talk while they are looking at it. It doesn't make a difference. Now, as you know, the importance with PFO screening came about because of the studies in the 2017-2018 that shows PFO closure is associated with a lower risk of recurrent stroke. The meta-analysis showed that if you do have a PFO that causes your stroke, closure is associated with a 60% lower risk of recurrent stroke compared with antithrombotic therapy. And this effect of closure is even more effective if your patient has large shunt or a large shunt with an atrial septal aneurysm. The reduction is up to 80%. Compared with the patients without this anatomical features, where the reduction is only about 20%. The thing you need to be mindful of is you want to close a PFO is you need a good cardiologist because complications can occur and you need someone with good hands, just as you need someone with good hands to do an atherectomy. It is well known also that if you do PFO closures, your risk of atrial fibrillation is increased by 4 times. But most of the time, atrial fibrillation occurs early and resolves within the first 2 to 3 months. Now, the long-term consequences of whether you are more likely to get atrial fibrillation after PFO closure is still not known. The information is not out yet. And if you don't want to use microemboli monitoring for TCD to look for paradoxical emboli, you can use it to look for high-risk plaque. You monitor it, but without doing the agitated saline. If you have an asymptomatic carotid stenosis and your surgeon wants to operate, he tells you it's 80%, it's very severe, we should operate. But you say it's asymptomatic, I'm not too sure the risk benefit. You can consider using TCD to look for microemboli. You monitor for at least 30 minutes downstream to 1 hour. If you do find incidental microemboli, what the data shows is that asymptomatic carotid stenosis that do have microemboli have a higher risk of recurrent stroke than those who are microemboli negative. The risk of stroke is about 3.6% per year if you have microemboli. And the risk for ipsilateral stroke is 5 times higher in asymptomatic carotid stenosis with microemboli than those without. So you can use microemboli monitoring to differentiate a high-risk asymptomatic severe stenosis from a low risk. In the earlier years, microemboli monitoring was also used to monitor the effect of dual antiplatelet therapy in patients who were actively throwing microemboli, and these patients were treated with DAPT. This is just a surrogate marker to show that microemboli counts reduced because I gave DAPT. Next, we go on to cerebrovascular reactivity. So I have another patient for you. Mr. B, 65-year-old man who presented with a left mild hemiparesis. But surprise, surprise, his MRI showed bilateral infarcts. And the infarct hinted at a bit of a watershed. On the right side, small on the left side, but he presented symptomatic to the right side. And when the CTA was done, you can see bilateral, severe, extracranial carotid stenosis. In fact, if you look at the CTA, you get the impression that the left is more severe because there's poststenotic collapse on the left, whereas the right is not collapsed. He had a right carotid stented on the 12th. Here you can see the severe stenosis on B-mode power, on B-mode Doppler with a high turbulent flows. And here you can see the stent. You can see those little white dots around. That's the stent. And here you can see a patent stent after stenting. 2 weeks later, his left side was stented. And here again on the left side, you can see severe stenosis, turbulent flow, post-stenosis, very low flows, and another successful stent. Now the question is, how do you decide which side to stent, left or right? Both had stroke. We did the cerebrovascular reactivity for both sides. And as you can see, at baseline before any stent, the CVR was reduced on both sides, more reduced on the left side than the right side, which is consistent with the CTA that showed the left side was severe with post-stenotic collapse. After he had his right, but our radiologist felt that we should send the right side because the right ACA was bigger and supplying flow to the left side. So he said, let's go for the right side. That was our decision. We didn't know what to do. So after stenting, you can see a marked improvement in the CVR on the right side, and the left side did improve a bit, probably because of improved collateral flow through the ACA. And after the left side was improved, his CVR on the left side improved even better, and you can see that the right cerebrovascular reactivity has improved even better. So what exactly do we mean by cerebrovascular reactivity? It is a dynamic process. It is what is the reserve you have now. And when I stress you and ask you to do a 100-meter run down and up, does your brain send up enough flow to your head to cope with that increase in stress? So there are many ways you can assess this reserve. Now, this reserve should be assessed using cerebral blood flow, which is the volume of blood flow per unit brain per minute. TCD does not measure volume of blood flow. We look at velocities. You can use many modalities to assess cerebral vascular reactivity. You can use CT, MR, PET, or TCD. But I'm going to talk to you about the special application of TCD. So it's going to be TCD. We use TCD, and what do we use to stress the patient? We don't ask them to run. We use carbon dioxide. Why? Because when carbon dioxide increases in your brain, the arteries will dilate. When the arteries dilate, your blood flow, the volume of blood flow will increase, but fortunately, the velocity of blood flow will also increase, and we can measure velocity. You can increase carbon dioxide by asking them to hold their breath. You can let them breathe carbon dioxide, or you can give acetazolamide injection. All three techniques can be used. In our lab, we use 6% CO2 because we find it easier to put a mask and ask the patient to breathe. You can use these formulas to calculate it depending on what technique you're using, but the formulas are quite easy. Essentially, it's the maximum velocity with carbon dioxide inhalation minus your baseline, divided by your baseline, and divided by the time needed to peak. So what's the advantage of CVR? I just told you, it identifies a group of patients with severe carotid stenosis who are at higher risk of stroke. Earlier on, we talked about severe carotid stenosis. Asymptomatic, if you want to identify more severe risk among asymptomatic, you use microemboli monitoring. Here, if you have severe carotid stenosis, among the severe, who's even most higher risk amongst the severe, you can use CVR. Because if your severe stenosis has normal cerebrovascular reserve, they are lower risk. Those with impaired cerebrovascular reactivity have a higher risk of stroke, up to 3 to 4%. And even your asymptomatic severe carotid stenosis with impaired CVRs are at higher risk of stroke. You can also, impaired cerebrovascular reactivity also identifies a group of patients with severe stenosis who are at higher risk of developing cerebral hyperperfusion syndrome after revascularization. That's because intracranially, the arteries are maximally dilated. They've lost autoregulation. So if you immediately revascularize, they're at higher risk. And lastly, we tend to use the CT scan for this, but you could use this to use for specs selection. And lastly, I come to my last topic, sonothrombolysis, which is monitoring the occluded artery while giving alteplase. So I have a 65-year-old man who presented with sudden right limb weakness. CT scan was all right, so he received IV alteplase. Before he received IV alteplase, TCD was done, and the left terminal ICA and AC were patent and normal, but abnormal flows were found along the left MCA. So we gave alteplase and continued monitoring. And this is what the TCD showed. You had minimal flow, and then you started having normal waveform. It shows you that occlusion is now slowly recanalizing. There are Andrew Demchak has recommended the TCD equivalent of arterial occlusion. If you have no flows or minimal flows, you're likely occluded on TCD. And from this grade, if you go on to dampened flow and blunted flow, it may show signs of recanalization. And if you show stenotic flow or normal flow, you have a full recanalization. I mean, the meanings of the various flows my earlier speakers have spoken of earlier already. And is TCD accurate in acute stroke? A Cochrane meta-analysis looked at 13,000 studies. Of that 13,000 studies, they identified 9 studies where patients had TCD, TCCD with angiogram, MRA, CTA performed within 24 hours of symptom onset. And they found 493 stroke patients. And yes, TCD and TCCD is quite accurate for diagnosing intra-arterial occlusion with a sensitivity of 95% and a specificity of 95%. They're both equally accurate. So you can use it to identify occlusion if you don't have access to CTA and MRA. More importantly, how can sonothrombolysis help? Again, another meta-analysis because of many trials done on this. 7 randomized trials involving over 1,000 patients. Sonothrombolysis is associated with a definite increase in recanalization. You're 2 times more likely to recanalize an artery if you monitor them when you're giving IV TPA. But unfortunately, even though you have recanalization, this does not translate to a clinical improvement. There was no significant differences in 3 months favorable functional outcome, nor functional independence. So clinical improvement's not proven yet still. Fortunately still, intracranial hemorrhage is not increased as well. So ladies and gentlemen, I've come to the end of my special application. I hope I've convinced you that TCD can provide very useful complementary information about stroke that CTA and MRA cannot. At the very least, it gives you real-time invasive information about blood flow, including the detection of microemboli, which none of the other modality can detect. You can also look for steno-occlusive lesions during thrombolysis. The good thing about it is you're more likely to recanalize. It is more sensitive than a bubble transthoracic echo in detecting right to left shunt. It can also give prognostic information if you use microemboli detection, especially in asymptomatic severe carotid stenosis. And cerebrovascular reactivity tells you that the stenosis you're studying is so severe that it's caused hemodynamic consequences, and these arteries are at a higher risk for stroke. Thank you.